patient is unhappy. Many reasons for this, and my job here is to discuss if my surgical technique was suboptimal, and that is why the patient is unhappy. So if you realize that by now knee replacement is perhaps the most widely performed surgery across the world. In India alone, we are doing approximately 150,000 replacements per year. And this is constantly increasing at the rate of 15 to 20% per annum. And if you see the literature, that about 15 to 20% of patients are unhappy after this procedure, even up to 1 year. So knee replacement is not a very forgiving surgery, and it requires meticulous detail to every attention to every detail, and therefore it is highly very surgeon dependent as well. Now you've seen over these last 2 days conditions like severe varus, severe valgus, stiff knees, knees with implants, all kinds of things have been performed, and you realize that each one of these conditions require very different surgical attention to give a satisfactory result. We know for a fact these days robots are being sold very aggressively in the country, and we know that they can produce very reproducible bone cuts. But do we really need to be so reproducible? I have a big question in my mind. But one thing is for sure, one thing is very certain, that the soft tissue balancing is the crucial matter for giving a good result. So I will take you through the errors that can happen as we go across in the surgery. So error one is choosing the wrong incision. So if you choose your wrong incision, it will ruin your day. Skin problems like this will come to your practice and will make very unhappy, and solutions are not very easy for these problems, as you've seen over these last 2 days. So midline incision gives the best exposure. If you have 2 incisions, then use the lateral incision, because we know that the blood supply to the knee goes from medial to the lateral side. Cross the oblique incision at no less than 6 degrees, and transverse incision almost at 90 degrees. If you have 2 incisions, then you can use the midline, but at least leave 6 to 8 centimeters of bridge between the 2 incisions. The second error is inadequate exposure. And that was the time when MIS, or minimally invasive surgery, was talked about or sold very aggressively, and you land into problems because you do a lot of retraction of the skin, and we know that knee is a very superficial joint and does not handle or take retraction very well. So you get skin necrosis, non-wound healing problems, and you can even land up putting components which are malpositioned, and that is the last thing you would like to do. You can also land up problems of patellar tendon avulsion if you particularly have a stiff knee and you're trying to do an MIS technique. The third error is an inappropriate distal femoral cut. We know that it affects the extension gap. If you cut less, you will leave a flexion deformity on the table, and if you overcut, you will have a recurvatum deformity, and a flexion deformity persists to even 5 degrees of flexion deformity after surgery. The patient is going to be very unhappy, and we know that these deformities do not correct unless corrected on the table itself. Before making the distal cut, you must check the guide, make sure that you are using the right side, not the left side for the right side, and verify the cut section with the angel blade, and always check the extension gap with the spacer block after cutting the distal femur and the proximal tibial cut. The error 4 is inappropriate femoral sizing. If you oversize the femoral component, you will have an overhang and the soft tissue irritation, and you will also land up doing overstuffing of the patellofemoral joint with anterior knee pain. If you oversize the tibial component, it will produce persistent pain and tenderness on the medial side of the knee. You must know what system you are using. So if you use a smaller size component in an anterior referencing system, it may lead to a decreased posterior condylar offset. On the other hand, if you use a smaller size component in a posterior referencing system, it may lead to notching. And here is a case of mine. We notched both the anterior, medial, and lateral side, and within 10 days, she came back to me with this supracondylar fracture. Number 5 is error in appropriate rotation of the femoral component. I think this is an extremely important thing that you must not make this confusion. And I think all the questions that were asked to the surgeons from the podium was, how do you gauge your rotation? And the landmarks are, in primary knee at least you can see for yourself, the epicondylar axis, the white side line, and the posterior condylar line. And if you don't want to resort to any of these, you can go for a gap technique. So when you make your anterior cut, you must be seeing the grand piano sign, which was talked of yesterday, and also look at the posterior condyle before you make the cut and ensure that you're cutting more of the medial condyle and less of the lateral condyle. The sixth error is preventing iatrogenic injury to the medial collateral ligament. That is when you are making the medial cuts on the femur and the tibia. And if you don't protect the collaterals, then you can have a situation like this. This was a patient of mine a few years ago. I managed to damage the deep medial collateral ligament, and third, fourth postoperative day, the patient was unable to weight bear. The knee was completely opening up, and I don't know if this video will work. No. Okay, let's forget it. So we had to go in again and augment this torn medial collateral ligament with semitendinosus, semiglacis graft, and this patient ultimately did well. This was a 5-year follow-up of the same patient. The seventh error is a varus cut on the tibia. And this mostly happens because you think that the center of the ankle is the midpoint between the medial and lateral malleolus. It is not the midpoint, it is the point which is medial to the medial malleolus, medial to the midpoint, and failure to recognize this will lead to a varus cut on the tibia. Error 8 is tibial slope issues, and most current systems strive for 3 to 7 degrees of posterior slope. And if you give a excessive slope, you will have posterior subluxation and excessive flexion gap. If you do an inadequate posterior slope, you will have diminished size of flexion space posteriorly. Ninth error is an unbalanced knee. To me, an unbalanced knee is a failed total knee, and this could result from inadequate release or over-release, and asymmetrical medial and lateral joint space opening is what you're going to see. You can even land up having a mid-flexion instability, and this is because of inadequate posterior offset or an undersized femur. You leave the femur in extension, or you produce an excessive tibial slope. You can have an unbalanced knee with a flexion extension mismatch. Again, the video is not going to work. You haven't loaded it properly. Huh? So I'm sorry the video is not working, but this was a patient who had a flexion extension mismatch because the wrong size poly was used, and when we opened up, I could show on the video that this knee was dislocating and relocating, and all we had to do was change the poly. Error number 10 is unlocked poly. Sometimes in a zeal of enthusiastic closing up and finishing of the operation, you may feel that you have locked the poly because each poly has a different locking mechanism. And here's a case when we did not lock it properly, and this patient was balking for 3 months with pain on an unlocked poly until we realized that this poly was protruding out because this is casting a soft tissue shadow in the front. Over this, you see over there. And then finally, we had to open up again and put in a fresh poly. So unlocked poly is an uncommon complication, but it can happen at times, even in the best hands. Error number 11 is an intraoperative fracture. If you have a rigid varus deformity or a stiff knee and you are going aggressively with surgery, you can produce like this, a supracondylar fracture, which fortunately does not displace, and we could treat it conservatively, and this was because this was a stable knee. However, if you produce a supracondylar fracture, which is unstable, then we have fixed it in this case with medial condylar, with screws, and that was enough and gave a satisfactory outcome. Intraoperative fracture, you can also have on the tibial side, particularly on the medial side in a severe varus knee, where the bone could be very, very sclerotic. You put in your guide and then you start hammering with your punch, and you will have a fracture like this, which we produce this fracture like this. So I think in these cases you should identify and make a medial slot with a saw before you start your punch. So that is a lesson we learned, and we now practice it routinely, and we got away by putting a stem in this primary knee, which may have been averted in the first place. Then patellar issues are there. Error number 12. Patella is usually the forgotten part of the operation. We think that we have done the tibia and the femur well, and we want to quickly get out and get on to the next surgery. So patellar issues, patellar instability, issues like this, you can have because you have internally rotated the femur, or you internally rotated the tibia, or you have done an inadequate lateral release. Patella clung syndrome, not commonly seen these days. It's usually in the PS knee, where you have a fibrotic nodule occurred in the junction of the quadriceps mechanism and the patella itself. A patella baha can occur because you have put in a thick tibial insert or you have over-resected the distal femur. Lateral patella facet syndrome, you saw that patella was being thinned out after patella replacement in this morning surgery. So lateral patella facet syndrome is a known entity. Patients can be very unhappy on the lateral side of the knee if you have a very projecting lateral patella. Popliteus tendon dysfunction, this is lateral pain and snapping that patients sometimes complain of when the tendon subluxes over the retained lateral femoral osteophyte or an overhanging femoral component. Error number 13 occurs at the time of cementing. You must avoid the flexion of the femoral component because that will lead to flexion instability. So, and also you must remove all the loose cement and avoid repetitive movement of the joint while the cement is setting in. So I would like to conclude by saying that knee replacement is not just an exercise in bone carpentry. The implant happens to be a part of the operation, so you need to be very, very careful with the soft tissue handling and the soft tissue balancing so that you don't have unhappy patients. So to quote in the words of Bob Salter, whom I had a chance to work for a few months, that he used to say very often that practice does not make you perfect. It is perfect practice that makes you perfect. So I would end up by these 5 commandments that I have enunciated for you, that thou shall externally rotate the femur, that thou shall externally rotate the tibia, that use a smaller size if you are in between sizes, lateralize components, and thou shall prevent a varus cut on the tibia. Thank you very much for your attention.
Thank you, sir, for a wonderful lecture. Next up, I call upon Dr. Akash Sarogi. He'll be talking about unhappy knees in CR joints. Discussion about these lectures would be during the lunch time. We'll be moving to a live surgery. Revision, the revision knee, the academic session on revision knee will be after lunch.
Thank you, ORTHOTRENDS, for this opportunity. Thank you, Pachore sir, and the organizing team. So here I am to discuss the unhappy knees, as we know. And is there any role of an implant that you choose, whether it is a cruciate retaining or a posterior substituting implant, which helps with the happiness of the patient? So as we all know that routinely with our knee replacement surgeries, the dissatisfaction can go up to 20% in the surgeries. About 7% of these 20% are those patients who have got a normal X-ray, a normal clinical finding, and we cannot point out anything in our outpatient to why this patient is unhappy. So if we look at the National Joint Registry, we have almost 5% patients who end up with a revision surgery at the end of 14 years of follow-up. We know the most common reasons, which would be the aseptic loosening, the infection, and instability. Now, first year infection usually shows up if it is especially a gram-positive infection. 1 to 3 years is mainly revision for aseptic loosening and pain, and beyond 3 years, the pain is less likely a reason to be a cause for the revision. If we look at this data, the use of cruciate retaining knees is on the rise. where it was 65% used in 2010 in the Western world, is gone up to 71% at the end of 2018. Now, survival between the two implants has not been massively different. If we talk about the unconstrained CR knee with a fixed bearing, it ranges between 3 to 4.25% on averaging about 4%. And if we look at the posterior stabilized with a fixed bearing, it comes about 5.13%, which is about only 1% difference between the CR and the PS knee. What we definitely know is when we are using an uncemented knee implant, the PS design has definitely got a higher failure rate, which is the orange line which you can see on this. So looking at this busy slide, this is talking about cause of revision comparing between CR and PS. So if we look at this all-cause revision, there is a slightly higher revision rate with the PS knee with 4.37 and 3.43 with the CR knees. Aseptic loosening has been found to be slightly different, which is 0.83 with the CR knees and 1.35 with the PS knees. Of course, the periprosthetic fracture chances are slightly higher with the PS knees, and we need to be very careful with the box cut when we do it. So what exactly is the function of our PCL? The PCL is a point of, it helps in the point of contact in, okay, so if we look over here, the contact point with the knee extension and the knee flexion keeps on changing. And this PCL helps in the femoral rollback. Now the arguers would argue that we do get some rollback with the PS design as well because the cam and post mechanism, but the CR functions on the natural mechanics of the knee with regards to the femoral rollback. So there is no tibial post-cam problem in the CR knee for obvious reasons, so we would not have any impingement or dislocation problems. It is definitely bone preserving when you're not making that box cut, and we argue that there is some improved proprioception with the help of those PCL fibers. Of course, if you've got a tighter PCL, it may lead to an accelerated wear of the polyethylene plastic, and if you have a loose PCL, it may lead to a flexion instability. This loose PCL can be recognized at two stages. One is within the surgery and one is afterwards. During the surgery, you have got an option to now go to a PS construct or go to an anterior stabilized construct, which is a new talk of the town. However, sometimes the PCL can get gradually loosened over a period of months or years, in which case you will see it after the surgery in your X-ray and clinical symptoms. Talking about the PS system, it is much easier to balance the knee when you're using a PS system. Arguably, you've got better range of motion with the posterior substituting implant. And of course, the surgical exposure becomes a bit easier because you've now released the PCL, you can dislocate the tibia easily anteriorly. You have got problems with the cam jump. You have poly-post wear, and of course the patella clunk syndrome, which we just now discussed. So this is about the cam jump, where the post can rotate about in the cam, and it can cause the jump of the cam mechanism. Of course, there you can have some wear of the poly on the sides of the post. So is there a right answer whether CR or PS, which one will lead to a happier knees? The answer is we don't know. It is still inconclusive, and probably it's not as important as well. If we look at the available literature, the clinical, the radiological, and the post-operative pain has been no different with use of either implants. And looking at the Cochrane review, we have been able to prove that the range of motion is better with a PS implant, but only by 2.4 degrees. The Knee Society score is better with the PS implant, but only by 2.3 points. So is this really clinically relevant? Now, there are some cases where you would not want to choose a CR implant in the first place, which may include a severe deformity, like a severe flexion contracture, a severe bone loss, or a posterior lateral corner injury where the PCL is already overstrained. The more important thing is to understand that what exactly PCL does in a knee replacement surgery. Of course, when you recess the PCL, it helps in opening up of the flexion gap But what it also does is some reduction of the varus deformity in the extension as compared to the flexion. So talking more about alignment, now we have moved away to about well-balanced gaps. Some amount of malalignment is more acceptable if you have a well-balanced gap, and that is the key. It is important that we have a good slope when we are doing a PCL retaining, that is a CR implant knee. Suppose we have a steep native slope of the tibia, like the dotted line which you can see on this figure. And we end up taking a cut which has got a lesser slope. We'll end up with a tighter flexion gap, and we may end up cutting a tibia a bit more so that the PCL may become completely dysfunctional later on. The second scenario being that, especially with Asian females, we always concentrate on the AP diameter of the femur, but the mediolateral diameter of the femur may be much less as compared to the AP diameter implant. So with a sized AP diameter, we may have a big overhang of the component, which we never accept. In this event, what we eventually do is to fit a good mediolateral fit, we may undersize the femoral component. The moment we undersize the femoral component in a CR implant, we end up cutting a lot of posterior condyles, which may again make the flexion gap unstable. So this is a very important slide which I would like you to take a picture of, that what exactly are the pitfalls in a CR and a PS implant. What we don't want to do is upsize the femoral component in the cruciate retaining knee. The reason being, if you do so, you may have a tighter flexion gap. What you also don't want to do is over resect the distal femur, because you may completely lose the attachment of the PCL on the femur. If you have insufficient slope, if you take lesser slope cut on the tibia, you may end up having a very tight flexion gap. So you want sufficient slope when you're doing a PCL retaining implant. Last but not the least, you need to check your balance so that you don't end up having a very tight or overtly loose PCL. Definitely a CR implant will allow you lesser joint elevation as compared to a PS implant. So this is an example of what happens when the PCL becomes gradually loose. What you end up having is a reverse femoral rollback instead of a normal femoral rollback. And this is inevitable because this has happened after the surgery, even without injuring the PCL during the surgery. Now, coming to the most important topic, which is the patient satisfaction. Now, we as the surgeons want to try our best that we do the proper surgery for the patient with well-balanced gaps. But is that enough for getting a satisfied patient after the surgery? The answer is probably no. These are the most important reasons for patient satisfaction versus dissatisfaction after the surgery, which includes any remnant pain, which may be explained or unexplained, whether we have met with the patient expectations, whether patient is able to do his regular activities actively. If the patient needs to have any operation done again, whether it is form of patella resurfacing or anything at all, the patient may have lesser satisfaction after the surgery, and of course overall hospital experience of the patient. Now nowhere in this the implants, PS, CR, the neo design, vitamin E poly, none of these count over here when it comes to patient satisfaction. So it is very important that we prevent dissatisfaction in the patient by managing their expectations. So we need to know before the surgery that what our patient was expecting and not after the surgery. It has been found that pre-existing anxiety or depression has got a very significant role with patient having a satisfactory surgery. And of course, we talked about the well-balanced gaps. One important point to note is that we are doing TKR in more and more younger patients. So they may come to revision after 15 years, 20 years. And it is important that when we are revising this implant, it is easy to revise a CR implant to a PS implant. But a PS implant, we may not always be able to revise to another PS. We may require higher form of constraints. So choice of implant is essentially on how we are trained. If someone is trained to do PS surgeries, he must continue to do PS surgeries, and likewise for CR surgeries. Not so well balanced CR is going to have much worse outcomes. So we can say in short that probably PS is little bit more forgiving as compared to a badly done CR. Thank you so much.
Thank you so much, Dr. Akash. I now call upon Dr. Leo Joseph. He'll be talking about supporting literature in unhappy patient. An announcement, the next academic session, that is on revision TKR, will be done before lunch, so please stay on.
Good morning. Sincere gratitude again to Dr. Vikram Shah and Dr. Pachare for having invited me here. Even though joint replacement surgery is one among the most reproducibly successful surgeries in orthopedics, even in the UK, it is suggested that only 32% of patients who are considered candidates for surgery actually do consent to it. There must be quite a few reasons why nearly 70% of patients refuse surgery. It could be the fear of surgery, if not in the UK, at least in India, the cost of surgery. But more importantly, it could very well be the fact that the quality of life that these patients perceive even without having to undergo surgery is good enough for them to not contemplate undergoing surgery. Let us not forget that there is no direct relationship between the level of symptoms and the radiographic severity of degeneration that we assess. We also know that even among patients who do consent to surgery, up to 20% of patients are not happy with the quality of results that they have obtained from the surgery. And why is that? I have had the opportunity of meeting with and learning from that wise little old man right in the middle, Michael Freeman. He has done a lot of work in orthopedics and taught us a lot of things, including how the knee moves. And if you have read his work, and including the work of some of the subsequent authors who have come about, you will know that the way the knee moves is such a complex interplay between ligaments and tendons and muscles that there is no way any prosthetic joint is going to reproduce that kind of a native natural knee movement. This in fact has been put into as a hypothesis by Nobel in this, and they called it the impairment hypothesis, because of probably which quite a large number of our patients are actually unhappy with the quality of their knee joints post-operatively. We also know that there is a significant mismatch between what we as surgeons perceive to be a successful result of surgery, as well as from what our patients perceive to be a successful result of surgery. There are a few factors which have been associated with the satisfaction. For instance, for some reason, female patients appear to be particularly difficult to satisfy. But there are logical reasons why both the young age and the old age are likely to be more unhappy with the results of surgery. For instance, in the young age, they're going to be extremely demanding on their prosthetic joints in terms of physical activity, and probably any design of joint is likely to underperform in those circumstances. And in the old age, these patients are likely to be associated with so many comorbid conditions, including osteoarthritis of other joints, including their spine, that they are not going to obtain the maximum benefit of just a knee replacement surgery. Rheumatoids are probably most likely to benefit from the surgery if their symptoms are largely due to secondary osteoarthritis from their knee joints and they are in good remission. However, these are patients who are often resigned to a lifetime of medications and chronic pain and synovitis that they are often depressed. It has been demonstrated that a pessimistic personality trait has been associated with dissatisfaction from surgery. Scott et al. In their analysis of more than 1,200 patients did suggest that a preoperative depression was significantly associated with increased rates of dissatisfaction postoperatively. Also, quite a large number of our patients are likely to have some amount of pain in the postoperative period. It eventually does go away, but then if not adequately counseled, they are likely to perceive this as a potential failure of surgery. Fortunately, Brander have suggested that even for those patients who have a heightened perception of pain at 1 year, they do eventually improve in their quality of pain perception and in their satisfaction rates at 5 years. How good is function as a determinant of satisfaction? It should be logical that postoperative functional results should determine the satisfaction rates from surgery. But while gross deficiency in function postoperatively compared to the preoperative function should be associated with dissatisfaction, however, functional result as such has not been demonstrated to be a significant factor determining satisfaction rates postoperatively in this large analysis of patients from the Swedish Joint Registry by these authors. Scott et al. Also assessed the functional results of surgery and found that there was no significant difference in the functional scores between those patients who reported satisfaction and those who reported dissatisfaction with surgery. However, those patients who said they were satisfied from the surgery did demonstrate a better increase in the functional scores compared to their preoperative scores in comparison to those patients who were dissatisfied from the surgery. How good is mechanical alignment a factor in determining satisfaction rates postoperatively? Well, there it is. In this Swedish Joint Registry report, no matter how good, how costly the equipments that you used, whether you use cast, whether you use robotics, there is no difference in the mechanical alignment in the results of in terms of satisfaction from surgery as demonstrated by radiographic assessments of these procedures by blinded radiographs. So, one common denominator affecting satisfaction rates in both these studies is depression, and that can significantly affect preoperative depression, can affect postoperative results from surgery, which brings us to the concept of managing expectations, because there is a sufficient body of evidence to suggest that preoperative expectations from the surgery can significantly affect satisfaction rates from the surgery. Which brings us back to the first question, that is, if even in the UK only 32% of patients consent to surgery, this number should be even less in India. And we as surgeons work under various pressures and considerations of practice, and even if for the good of our patients, we will have to end up convincing our patients to surgery. And by definition, convincing will mean to try and entice them with possibilities and increasing their expectations, while on the contrary, we may actually be prudent in trying to temper their expectations, even in those patients who are eager to undergo the surgery. Which gives us two options essentially. Either you increase expectations and you underdeliver, or you temper their expectations and overdeliver. And I think prudence will tell us to choose the second option. Thank you.
Thank you very much. We now move on to the next session. I would like to call upon Dr. Amish Kshatriya sir on dais, please, to moderate this session. First of all,
Sir,
yes.
during lunch.
Discussion after lunch. This session would be about revision knee surgeries. Firstly, I would like to call upon Dr. Srirang Devdas sir, Senior Most Surgeon in Shalby Hospital. He'll be talking about principles in revision knee. Can I invite Dr. Leo Joseph to be on dais, please, to moderate?
Thank you very much. First of all, I'm extremely sorry for keeping you away from your much-deserved lunch. And secondly, what I'm going to discuss just now in next 5, 6, 7 minutes, most of that has already been covered during the live surgeries. So as far as possible, I'll try to run through everything. We all know why TKR fails. In the early period, first 6 months maybe, infection is the #1 cause. Later on, it is loosening or aseptic loosening is the main cause. There are different failure mechanisms. The wear of the insert, that is a plastic, infection, aseptic loosening, and periprosthetic fractures, instability, and malalignment of the components. These are the failure mechanisms. It differs from primary knee surgery because you need a better infrastructure. The surgical team has to be more experienced. A lot of preoperative planning goes in. The important challenge is removal of the well-fixed implant. You have to take care of the bone stock deficiency that is present or man-made when you do the surgery. You have to select the implant accordingly, and you have to ensure that there is adequate inventory which is available in your hospital. And of course, post-op rehabilitation is much different from the primary surgery. The clinical workup comes first. Varus valgus stress test gives you a fair idea regarding the medial and lateral collateral ligaments. And in case you suspect neurological deficiency or muscular weakness, it makes sense to have a proper neurological assessment. If required, you can take the services of a neurophysician, get an MRI of the spine done, or whatever you think is fit. EMG NCV also does help. Always rule out infection before going for revision surgery. X-rays and CT scan done before surgery are very helpful. They show you whether there is malalignment. The stress views, varus valgus, tells you about the status of the ligaments that you have to deal with during the surgery. X-rays give you a fair idea regarding the bone defects and what to do about those bone defects. And a CT scan helps you decide whether the femoral component is rotated properly or mal-rotated. The revision TKA surgery can be divided into various parts. Number one is exposure. After exposure, you take a sample of fluid and the synovium for test, as was shown during the live surgery. The removal of existing hardware or cement spacer has to be done without damaging the bone and soft tissue. Then you assess the knee, the bone defects, the condition of the ligaments and the patella tendon. Rimming the canals for stem extenders. And then the use of bone grafts or metal augments or metaphyseal sleeves to fill the bone defects. Matching flexion extension gaps, at the same time finding the rotation of your femur and sizing of your femur is important. And then you decide the level of the constraint that will be required for a proper knee replacement. You do trial, and once you are happy with the trial, you go ahead with the cementing and closure. When it comes to incision, if there is a single incision, use the same one. If there are multiple, prefer the lateral one or the most recent one. In parallel incisions, keep adequate skin bridge between the two, more than 6 centimeters. In small size females that we have in India, sometimes it is difficult to have 6 centimeters between the two incisions. Avoid acute angles. In tightly adherent scar, keep a plastic surgeon ready. That is what we do in Shalby. And take care of the patella and tendon and your ligaments when you expose. As was shown in the live surgery today, if you find that you don't get adequate exposure, you go for a quadriceps snip, or rarely a tibial tubercle osteotomy. Now, the removal of well-fixed implants is an art and has to be done patiently, or else you end up losing bone or breaking bone. Most of the orthopedic surgeons that I've met are very impatient, so this is most important for orthopedic surgeons. The removal of well-fixed femur or tibia is done with the help of multiple osteotomes. You can use a ghillie saw wire or a recip blade. Before you start this, it makes sense to lightly tap the well-fixed femur or tibia with a hammer. This helps debonding. Or you can use multiple osteotomes. You can stack them up, and then you can remove a well-fixed tibia. The same thing applies for femur. During this procedure, see to it that you don't damage the native bone. The reconstruction principles are quite simple. The goal is to achieve kinematic stability. And how you do it? Recreate the flat tibial surface, either with the help of your cutting of your tibia proximal, or maybe use your augments to do it. Recreate the femoral, the flexion and extension spaces. Maintain joint line. Build up extension space. It is always required. This is the classification of bone defects, type 1, type 2, type 3. I won't go through all of this because I don't think we have got much time left. On the femoral side, you have posterior bone defects, distal and anterior. The anterior one are filled with cement. The distal and posterior are taken care of with the help of metal augments. And you use a stem extender in femur and also in tibia to stabilize your implants and to negate whatever cantilever forces there which are acting. So here you can see the distal defect in femur, which can be taken care of with the augment. There are multiple augment sizes available. Same holds true for the posterior defects in the femur. And to achieve rotation, you may have to juggle with the sizes of the posterior augments on the medial and lateral side. For type 2 defects, these are the metal augments available. They are the half blocks or full blocks. Type 3 defects, you can use metaphyseal sleeve or cones. Here you can see the metaphyseal sleeve being used in femur. Use least amount of constraint which is necessary. So the first choice is change to a thicker poly or go for a TC3 or CCK type of an implant, that is non-link constraint prosthesis. If this doesn't work and you still find that there is instability, then you can go for a rotating hinge knee. Thank you very much.
Thank you, sir. Next up, I call upon Dr. Riyad, who will be talking on principles of sleeves.
Thank you. So we have seen what to do in total knee. It's not always so easy, as we have seen during the surgery this morning. So I'm going to speak of my experience with metaphyseal sleeve. So that was my first sleeve. And we had the experience of backside wear. And backside wear is terrible for osteolysis and huge bone defect. And at this time, I had so much bone missing. I say, I'm missing. So I did a stage, and finally I did noise, rotating hinge prosthesis, and this patient died 10 years later with a well-fixed sleeves. So I think at revision we are dealing with bone defect, which can be large, and the quality of the bone is not so good. So we have to do this reconstruction, and it's very time consuming. We spend a lot of time using bone graft in the past. So achieving solid fixation is really essential for short term, for early mobilization, weight bearing, and also with hopefully improve the longevity. So these are the two challenges in the revision. I think now we are looking at bone defect a bit differently. We are, because of the experience of noise and all these sleeves. So we are looking now at zonal fixation and yes. So we are looking at the epiphyseal area where usually we can use augments. Then at the metaphyseal area, how to get fixation here and the sleeves are one answer. And then at the diphyseal area with the stems. And that's the way now we look, how can we achieve good fixation with our surgery. And then we discovered that, when we look at the failure of fixation in revision knee, we had failures on the femur more. And finally, we discovered that's because we did not get good rotational stability. When you have slight missing posterior condyle, I mean, augments are fine, but when it's a complete condyle defect, well, we are pleased with the stem in the coronal plane, but when we look in flexion, it's rotating. After many stress, it's rotating around the stem. So metaphyseal sleeve is a way to circumvent the bone defect in flexion. Okay, so cementless sleeves, well, they are good to fill the defect, and you crush the bone until you get really a good fixation, stability, and maybe we improve the fixation because of the step design, which convert the shear stress with a step design. And besides, you have porous coating. Now you have full porous coating all over the sleeve if you want. You have the problem with the connection. You see that there were some failures reported in the literature, so you have to be very careful when you are assembling your sleeve. Well, that's a simple case you can handle with a sleeve. Well, when we look at revision of a uni, we see that it's not, we may have some loosening on the tibia. And I think today we will not use the stem. Okay, zone 2. Oh, well, that was terrible. We were spending so much time to reconstruct this defect with a condyle. I think now we can do it much faster, and that's very important to try not to have infection with this long-lasting revision surgery. So I think in this zone of the metaphysis, the metaphysial fixation, I think, provides cementless good fixation. I think that's very good. Close to the articulation, we will see it's important because it facilitates the restoration of the joint line and maybe it decreases the flexion gap. And so that's quite good. And sometimes the access to the diaphysial is quite difficult, and so we may not need a stem or offset stem. And if you use offset stem, I think you have to use a cone. We can't do it with a sleeve. And that's a typical case. We have no bone support on the metal plate, and well, we are used to see this with the LCS primary. No, you see this case, 2 sleeves, no stem. That's what we do quite often now. And the problem is in this metaphysical defect to know how much bone contact we have. And still, this is not very, very clear. Maybe sometimes we need to do grafting. So, and the problem now is when do we need a stem? I think Ray spoke about this yesterday. And I think stem may be necessary because the quality of the bone, because the bone defect does not allow you to get primary stability, or when you have a fracture, to bypass a fracture, and maybe with hinge, we need this. I think I will go quickly because we discussed yesterday stem or no stem. Well, I think this is a big problem. When you have a curved femur, and I think most of the time we get a big flexion gap only because we have a curved femur, and if you go further, it's a problem, and if you use a big stem, it's even bigger. So that's still a problem, and we are cheating during our surgery in order to avoid this problem. So here we see the problem that we can have because we are cheating in order not to have a big gap, and you see the contact at the tip of the stem, and we have to be very careful when we are reaming. After infection, I think the bone defect are really a problem after infection. And you see here how much bone is missing, and I think the metaphysial sleeve is a big help in the revision cases. And here you see cases, no posterior condyle, and you see this case 15 years, 14 years later, we have good stability, and we already get a good stability. It's severe backside and infection, and we were able to reconstruct this. This is one case in India. The problem with the sleeves in India is it's so big. This case I had to put wires, and I spent my time to try to fit in. It took me a lot of time not to break anything, and finally she is fine. I saw her last year. And sometimes, well, we have more difficult cases, and now we can use a diaphysial sleeve. I think this is a good way to get fixation. You want to see a big case from Dr. Well, I think this we know. Well, when we studied the fixation, the bone fixation on the remove sleeves, you see it's only it's not fully covered with a bone osseointegration, but we see the same thing with a cup in the hip. A fracture, This was reported at the femoral adapter. I think we have to be very careful when we fix it during surgery. And here, that's also another case. So I think it's a very good solution. We have to be careful the way we use it, and I think the flexion gap is really a big issue. Thank you.
Thank you, Dr. Brier. I now call upon Dr. Sion. He'll be talking about stability in revision knee replacement.
Okay, thank you again. So restoration of bone loss and neutral alignment and stable extension and flexion gap are essential factors for successful total arthroplasty. So minimum bone loss during implant removal is a beginning step to get a stable revision knees. So we need adequate exposure and patience to remove host bone as much as possible. I usually use the power saw and flexible lemur, and sometimes I use the hammer to remove the components. The first step to get a stable revision knee is to reconstruct a stable proximal tibia using bone grafts or metal blocks. But we have to remove the minimal bone section from the proximal tibia. Tibial tray should be seated on the intact tibial limb. Usually we have to use the stem to provide the stability of the proximal tibia. So we have to, we already mentioned about the joint line, but anyway, we have to maintain joint line as much as possible. Usually we use the metal block or structural allograft to augment proximal tibia, but sometimes we can use for metaphyseal defect, we use the tantalum cone or metal sleeve. But in the revision situation, the maintaining joint line is not so easy. Sometimes we have to accept the joint line elevation, but it should be less than 5 millimeter elevation, even in we use the hinged knee. The second step, previous speakers already about flexion and extension gap, but I usually establish the flexion gap first in the revision situation using ideal size of the femoral components, but the reference can be a pre-TKA X-ray or contralateral lease. We usually augment with metal block on the posterior aspect. The femoral component rotation is also important to make balanced flexion gaps, but the distal femur geometry is disrupted in some cases. So in that cases, the tibial platform can be a reference for the rotation of the femoral components. So then we establish the extension gap same as flexion gap. So usually we augment metal block or structural bone graft on the distal aspect, then then move to distal side of the femoral component, as you can see in this slide. Then if flexion gap is larger than extension gap, maybe we try to take up PS poly, but if the gap is more than 5 millimeter larger than extension gap, maybe we have to change valgus constraints instead of PS knee. So this is a well-known tables how to solve flexion and extension balance in total arthroplasty. In revision situation, usually flexion and extension are both gap is loose. So if extension is loose, maybe as I mentioned before, we move to femoral component to the distal side, then we augment with metal block or bone grafts. If flexion is loose, maybe we can use the larger size of the femoral component with metal augmentation. But if even though we use the ideal size of the femoral component, still flexion gap is larger than extension gap, more than 5 millimeters, maybe we can use the PVC components. But only few cases, maybe we can use the hinged knee. The third step is to choose proper degree of constraint polyethylenes. So usually CS or CLE is not permissible in revision situation, but ideally I always try to use PS insert instead of PVC or hinged knees. But sometimes it is not easy to balance flexion gap as extension gap. Only that case, maybe we can use the PVC instead of PS knees. Then, so as I mentioned before, if flexion is too large or mediolateral stability is, I'm not sure, maybe we can use valgus constraint instead of PS knee. But even though we use the PVC, the MCL should be intact. If MCL is deficiency, maybe we can do ligament reconstruction, or ligament reconstruction is impossible, maybe we have to use hinged knee instead of PVC. So if we follow this kind of steps, maybe we can get this kind of good instability even in revision situations. So I will briefly show our data, more than 2,000 cases with a minimum of 2-year follow-up. The main cause of revision was infection, then loosening and instability. So I used about half cases of revision using PS knee, and 40 cases of revision I was used the CCK implant. Here is the results. The range of motion is usually larger in PS knee than CCK knee, and failure also, we observed 6 cases of failure in PS knee and 8 cases of failure in CCK knee. CCK knee failure is a little bit larger than PS knee. So if sometimes we have to repair the collateral ligaments using screw like this, then sometimes we use edge bones. If the bone stock is too much, then we also sometimes we can reconstruct the MCL using hamstring autografts or allografts. Here is a case of global instability. I used the rotating hinge, but after 1 year, the can be fractured. So in that case, just I can internal fixate. But we should use less constraint as much as possible. The condition is permitted. So Rhizotomy is a quite difficult situation. So only patients have rhizotomy. In that case, I use the hinged knee instead of CCK components. This is global instability. At that time, just I changed the polyethylene insert, but rhizotomy is a recurse, so that's why I convert to rotating hinged knee. So this is take-home message for stable revision knee. We have to try restore bone loss and joint line. Then we have to balance flexion extension gap and choose less constrained instead of highly constrained knee. Thank you for your attention.
Thank you very much. We can now move on to lunch. We'll finish the remaining lecture